Good afternoon, everybody. My name is Anouk Bosma. I'm an MHPSS technical advisor with AI at the PS Center. And today I'll talk to you about MHPSS before, during, and after radiological and nuclear emergencies. Yes. So the only, luckily, atomic bomb that we've ever experienced were actually two bombs in Hiroshima and Nagasaki in 1945. As of today, they're the only use of nuclear weapons in history used in armed conflict. And sadly, targets were chosen because there were large urban areas that also held military significant facilities, which was pre-Geneva Conventions in 1949. And as a result of that, most of the dead were civilians. The effects of the atomic bombings killed between, in total, 260,000 to 450,000 people, with roughly half of the deaths, between 130,000 and 225,000, occurred on the first day. And the 2 to 4 months that happened afterwards, those people died from burns, radiation, sickness, and injuries, compounded by illness and malnutrition. Then nuclear accidents, we've had quite a few more. The largest two being Chernobyl and Fukushima, happening in 1986 and 2011. These are the only two nuclear energy accidents rated as a 7 on the International Nuclear Event Scale. Chernobyl, first of all, in the north of Ukraine and then Soviet Union, is the worst nuclear disaster in history still, both in socioeconomic costs and number of casualties. However, that sounds, if you just compare it to Hiroshima and Nagasaki, only 31 to 54 people died from the immediate impacts of the immediate blast trauma and acute radiation syndrome in the seconds to months after the disaster. And 60 people died in a total decades since, inclusive of later radiation-induced cancer, cardiovascular disease, and other diseases related to the disaster. However, 335,000 people were evacuated. And also the initial emergency response and the later decontamination of the environment involved 500,000 personnel. It costed $68 billion, even with inflation included. There is, however, debate around the accurate number of projected deaths, long-term health effects, because that's with nuclear and radiological emergencies. Most of the impacts happen longer term. The estimates range up to 4,000, according to a UN report that came out in 2005-2006 for the combined countries of Ukraine, Belarus, and Russia. Fukushima, on the other hand, the most severe nuclear accident since Chernobyl, which happened in Okuma in the Fukushima region in Japan, which was caused by an earthquake and a tsunami that happened in 2011, caused nuclear meltdowns, hydrogen explosions, and the release of radioactive contamination, mostly caused by the tsunami. Days after the accident, the radiation went into the atmosphere, culminating in an evacuation zone of around 20 kilometers, and 154,000 residents had to be evacuated. The airborne radioactive contamination from the damaged reactors continued for some time, but especially the water contaminated was quite a large risk. Even 2 years later, they still found quite high levels of contaminations in the Pacific Ocean. Having said that, up till now, since 1945 to 2007, we've had 35 nuclear accidents, including Chernobyl and Fukushima, which only resulted in 255 direct casualties, which is a disputed number, but still, compared to other emergencies, a relatively low number. And even the indirect longer-term casualties lie between 15,000 and 60,000, which is high, but if you compare it to other emergencies, the impact relatively remains quite low when it comes to direct casualties. However, other effects, burns, acute radiation sickness and syndrome aside, including injuries, it's mostly the environmental, socioeconomic, and especially the MHPSS impact.
You're mute, Anouk.
Mute?
She's frozen.
You're frozen, Anouk.
Can you hear me now? Hello?
Yes.
Okay. Good, because I didn't mute
I
myself.
can hear you, but you are not mute.
You cannot hear me?
I can hear you. Maybe we lost the
I can.
Maybe it's on your... Can somebody maybe text them that the problem?
Yeah, I'll do that.
Thank you. Then I can just keep going. And let me know if you can't hear me. Aya, maybe you can alert me.
We can hear you, sorry.
You can read, no, but I think the problem may be on your end.
Yes, the action.
Yeah.
Yeah.
Now it's okay, now it's okay.
Okay, perfect. Just know that the problem may be on your end. It seems to not be on my end. Okay, let me continue. So the MHPSS impacts are much higher. And the probability of an accident is actually also really low, as you can see on this PowerPoint. Only one in 3,704 reactor years, there will be one accident. So the probability of that is actually quite low. And as of an accident, of course. The impacts, also people are quite counterintuitive, what people might expect. As a United Nations Scientific Committee found together with the World Health Organization in a recent report, there was actually no increase in miscarriages, stillbirths, or physical and mental disorders in babies born after a nuclear accident. And that actually evacuation and sheltering to protect the public significantly reduced the risk by a factor 10. However, an ongoing intensive cleanup program to both decontaminate Fukushima affected areas and decommission the plant itself will take 30 to 40 years. So the impact is really long-term. What guidance exists? In 2020, WHO came up with a framework for MHPSS and radiological and nuclear emergencies. And it is their initial step towards integrating MHPSS within existing radiation emergency preparedness and response arrangements. They recommend a public health approach with an emphasis on MHPSS, actually. And they say it must include interdisciplinary capacity building to ensure MHPSS is integrated within existing arrangements for the response. They also state in this report that the radiation emergencies have unique mental health impacts. The MHPSS consequences are mostly fear, anxiety, emotional and behavioral changes that may actually outweigh the direct health impacts of radiation exposure. That's what I try to also show you a bit with the actual impacts. Practical tools need to be developed in order to promote the integration of MHPSS within existing radiation emergency preparedness plans and protection actions. And what's very interesting is actually that they say there's more research needed to further understand the mental health vulnerability to radiation emergencies and to strengthen the evidence base for appropriate actions. Within the movement, we also have some guidance, especially as you can, both the atomic bombs and Fukushima happened in Japan. So Japanese Red Cross Society has quite a lot of expertise in this regard. They've developed these guidelines, which have been translated into English in 2015, the Nuclear Disaster Guidelines, and also the Red Cross Nuclear Disaster Resource Center has made a publication on communication with affected people during a nuclear disaster, which is quite short and easy to use. MHPSS specific guidance also is included in the IFRC Nuclear Radiological Emergency Guidelines, which focus on preparedness, response, and recovery. They include this little briefing note that you can see at the bottom that I will get much more in depth about in a few seconds. I just want to note that it's in the chapters, these chapters that you can see in the PowerPoint. There's psychosocial support and care for staff and volunteers, very short. Communication and psychosocial considerations, also very short. But then the psychosocial interventions is actually published as a whole guide note in the guide. You can find that in chapter 11. This is the note that I was just talking about. It actually stems from 1996 and was updated in 2011. And we'll try to update it soon because it still mentions Chernobyl being a 10th year anniversary. So it's a bit outdated. But actually, as I went through it, it's still very up to date when it comes to its recommendations. So in terms of its actions, you can actually start using it straight away. And the good news, this is on a slightly sarcastic, ironic note, is that the pandemic has prepared us really well. As the impact and measures, it's very similar in nature, as you will hear in a few seconds, except for obviously some differences and dependent on the nature of the emergency. Why is it so similar? Nuclear radiation, like a pandemic, is invisible. And the effects of contamination may persist for a long time after the effect, also similar to the pandemic. And environmental contamination, which is quite different, obviously, in various ways, may necessitate evacuation. And that's one of the major psychosocial impacts of such an emergency is the need for evacuation. And also the uncertainty and or contradictory public health information is one of the greatest risks that people are exposed to, which you can also compare to the pandemic. People really need information about health risks and the appropriate actions to take And also the lack of this information may increase medically unexplained symptoms. Similar again to the pandemic, personal protective equipment may cause distress for staff and volunteers. And unlike the pandemic, if the threat is perceived as a terrorist attack, this will also increase the effects on mental health and psychosocial well-being to be worse. I will quickly go through this and speed up to the psychosocial interventions, but I just really want to focus on this public information, as also unaffected portions of the community have to be included in this campaign, not just the survivors. Effective risk communication is timely, uncomplicated, and empathetic, and displays empathetic information about the nature of the risk, exact prevention methods, availability of evaluation and treatment. Also, again, similar to the pandemic, where can I get tested? How do I know if I'm not sick? And the information also to obtain relief efforts has to be culturally sensitive. And as again said before, epidemics of medically unexplained illnesses may occur, and the health system has to be prepared for that. Now, speeding up to the interesting bit for this group, the psychosocial interventions. As usual, we recommend community-based psychosocial systems to be integrated with general health services, as this is primarily will have health effects. Setting up vertical mental health services are, as usual, discouraged. And we need to tailor our systems to the needs of different subpopulations. Just a reminder, as always, the Hobfoll principles around psychosocial support, hope, safety, calming, connectedness, and self and community efficacy will really have a great impact on how you design not only your psychosocial support activities, but also the impact that they may have on the population. I won't go through all of this, but I'll talk you through the major points. In the emergency phase, as always, train volunteers and staff, including in health facilities, on psychological first aid. And maybe orient them also around loss and grief. These are the two pictures that you see there of the loss and grief module in the community-based MHPSS training that we have at the PS Center. And the picture is from the online PFA module on grief and loss that was created during the pandemic. This orientation and fearful responses to distress may also need an orientation to staff and volunteers, so they're able to recognize this with people they're interacting with. And don't forget to support first responders and health workers. Like in the pandemic, they will be affected quite significantly. Create natural opportunities for individuals to share concerns and support. Active community engagement and accountability, CAA, always important. Concrete, purposeful, and common interest activities, and really important because also of this evacuation element, systems for long distance communication to re-establish links amongst family, friends, and loved ones. Spaces for religious, recreational, and cultural activities and events are very important, as are recreational school activities for children and activities for vulnerable groups in safe spaces. And then there are some specific evacuation considerations. The reasons for which an evacuation is necessary or even unavoidable must be clear. Again, this is about information, people feeling that they have a sense of control and agency still. People in the impacted area should be actively involved in the evacuation and other processes as much as possible, again, for them to exert their agency and that they have some influence on the process. That is unavoidable. Isolation, social distancing, and quarantine measures, and this is coming from a note that was written in 2011, imagine, may warrant specific guidelines on their own and could well exacerbate psychosocial issues. Again, the pandemic has prepared well. Spaces. Ooh, there's so much I go there. Am I still okay on time? And I'll just.
Sorry to
Yes,
say.
sorry.
We have just 1 minute left.
Have 1 minute left.
Okay, I'll go very quickly then. There's also the post-emergency phase, which is actually the last slide before I conclude, which focuses on outreach activities and psychosocial interventions, help seeking, promoting positive ways of coping. Again, think of the Hobfoll principles. Community worker training and supervision, basics of psychosocial support knowledge and skills. And again, this engagement with the community and referral mechanism are very important. And don't forget collaboration with faith-based leaders and traditional healers, as we just discussed in the prior presentations as well. I just want to draw your attention to one more note, the technical note on linking disaster risk reduction and MHPSS that was done by the Interagency Standing Committee. as this is primarily also an issue of preparedness. Obviously, I'm talking about something that hasn't happened. So we really need to think how the Sendai framework for disaster risk reduction is done at the same time as MHPSS. And you can see how these priorities of that framework are actually very in line with what we do in MHPSS. Some additional general preparedness and response guidance. IFRC on their learning platform has an e-learning module on nuclear emergency preparedness with practical guidance. And they recommend everybody currently deployed to the Ukraine operation to complete this training. They're also considering emergency CBRN kits, which stands for chemical, biological, radiological, and nuclear defense basic protection kits. They're looking into the need to purchase and distribute these. And in case of a sudden release of radiological contaminants, they may utilize those. That was it. Thank you so much.